Well, good morning, colleagues. I'm delighted to be here this morning to share with you a local government perspective on the direction of travel that we're engaged in. I'm advised that the standard definition of a revolution is the overthrow of a social order in favour of a new system. And I'd like to argue with you this morning that health and social care integration is indeed a revolution. I say this because it will change the historic regime in which the Health Board and local authority preside over a fractured system between social care, primary care and tertiary care. I say this because we are witnessing the rise of a new regime, the world of integrated joint boards and joint monitoring committees built to achieve significant, lasting and progressive change in our health and social care system. Like any revolutionary endeavour, there will be hearts and minds to win over. I can speak from experience and say that that is not always an easy task, and I have the scars to show it. I know just how far we've travelled within local government on this particular issue. The majority of COSLA's members initially asked us to resist these reforms, but as our internal debates unfolded, there was a recognition that the change being contemplated was both inevitable but desirable. It was inevitable in the extent to which the Scottish Government had the political capital and the numbers in Parliament to see it through, but it was also desirable in that it provided greater opportunity to redesign our health and social care system in response to epidemiological and population changes. There were and are consequences on the local government side of the business which continue to give pause for contemplation. For instance, the connection with wider local authority functions such as education or housing or regeneration, not to mention community planning partnerships. But these are interfaces that can and will be managed, and this inconvenience will be worthwhile if we can deliver the change envisaged. Perhaps you're thinking I'm rather overstating a description of a revolution at hand. After all, the continuity with the Health Board and local authorities' current delivery and governance system is an important facet of the proposed system, and one that we in COSLA fought hard to retain. So let me try to be more specific. To my mind, we are witnessing public service reform with two revolutionary ideas at its heart. The first revolutionary idea is that we should be designing the health and social care system from the bottom up, starting with the requirement to put in place locality arrangements. For me, locality planning is about more than just community-level coordination of services. It must be about empowering local people and local professionals to come together and consider what service and support arrangements are needed in their local community. It's about giving localities the power and control to shape their own arrangements and to be accountable to the local community for these decisions. It's about drawing on the best that the third sector has to offer, building community capacity, and designing formal services to complement this. This focus on locality planning is one of the animating ideas of the new legal framework, which comes closest to connecting with the central themes of the Christie Commission report on public service reform. So, why not just devolve everything to locality level? After all, that's where services and support will be most responsible to local needs. The reason, to my mind, is twofold. First, there is a clear need in some cases for aggregation. There is little sense in trying to run emergency medicine at locality level. There are some services within the health and social care system that are best provided at local authority, health board, and dare I say it, at national levels. Yes, our working assumption should be towards localising as much as possible, but that is not to say that it's always possible or desirable, so aggregation still remains important. The second reason that we can't devolve everything to locality level is that we still have to make strategic decisions that services population need. This can sometimes be done at a very local level, but not always. This point was made recently by one of our council leaders who observed in relation to the radical localisation of democracy that if we empower neighbourhoods to the extent that we have no decision-making capacity at local authority level, how would we then be in a position to make necessary but potentially unpopular decisions? The same holds for health and social care partnerships. Strategic commissioning requires us to think about population need across localities and about our service response to that, and in some instances to make unpopular decisions which may still be right. But the bottom-up approach is not merely expressed in the relationship between localities and the integration authority. It also exists between the integration authority and the parent bodies. For in the event that the integration schedule is agreed by the parent bodies, thereafter the integration authority has considerable power to influence change. Indeed, the placement of accountability within the new system has been the subject of much conversation, but much of it has, to my mind, misunderstood the import of the legislation. In the case of the Integration Joint Board, there is soft accountability to parent bodies expressed through its membership, but no direct reporting relationship. If anything, the law empowers the IJB to give direction to the two parent bodies. As a result, the accountability to Scottish ministers is even less direct. When considered in this light, we begin to see how much of a departure from the historical regime the new arrangements are, and how important it will be that integration authorities are properly accountable to their local populations. Some of you might wonder, what about variation within this context? How do we ensure there is consistency of experience across Scotland? Well, my answer to that is that I think we need to recognise that by dint of the fact that this is much more of a bottom-up system, we are deliberately creating a framework that responds to local population needs. So we will not see the same service response in every area, and nor should we want this. For that would be to fundamentally misunderstand the needs of our disparate communities and the differences that exist both between and within partnerships. If one locality has higher levels of need and deprivation than another, then it's right that resources weigh in more heavily in favour of the more deprived area and support a more comprehensive array of services. So there is a place for legitimate variation. The key ideal is equality of outcome, and that will be one of the overriding discussion points in today's event. How do we ensure that people within and between partnerships have an equitable outcome? Consider the outcome on health inequalities, which by definition requires an approach which is weighted towards the most marginalised and socially excluded citizens. How can partnerships deliver change on this agenda to the extent that it equalises outcomes across Scotland? In part, this might be about addressing the inverse care law, ensuring that access to health care is improved in our most disadvantaged neighbourhoods. It is precisely that kind of conversation I hope we will be exploring today. But just as we strive for equality of outcome, we must also recognise that we will come across illegitimate variation. This is the variation that comes not from a specific policy or commissioning decision, but from the randomness of clinical or bureaucratic judgments. To my mind, we need to tackle this type of variation head on, because if we don't, we simply propagate wasteful spending decisions. Our approach here, whether using IRF data to highlight different clinical judgments or the health and social care indicators to compare ourselves with other partnerships, must be about fostering a culture of self-improvement, benchmarking and public accountability. So, make no mistake about it, there will be a more heavily localised feel to health and social care integration from here on in. The legislative changes passed by Parliament do not merely amount to a redesign of CHPs with some add-ons. This is a new approach to the delivery of health and social care in Scotland. It is, in everyday sense, in my view, revolutionary. So, if that is the change, then why are we doing this? The answer to this question is if we fail to change, patterns of demand will simply swamp our statutory services. More and more people will flow into our hospitals and care homes. You've heard all of the stats, so I'll not focus on these again. But it's not just that we'll be dealing with greater quantum, larger numbers of people. The care input required is going to be more complex. Increasingly, citizens will present with multiple conditions, requiring a range of service responses involving different professional disciplines and specialisms. So the health and care social system definitely needs to change in response to this. We need to see change at every level. We need to cut the umbilical cord with the general hospital. Admission to hospital is still seen as the easiest and least risky option. We need to redesign our system to make the best option the easiest option, and that means more alternatives to hospital admission. And that is also why, incidentally, I was pleased to see the unscheduled care pathway under the commissioning, governance and control of the Integration Authority. And this, colleagues, is the second revolutionary idea contained in the integration proposals. If we are to truly commit to the idea of whole system change and to strategic joint commissioning, then we need to give partnerships permission to redesign the whole system, including acute care. If we are serious about shifting the balance of care, if we want to see less emergency admissions, if we want to facilitate quicker and safer discharge, then we need to give our partnerships the tools to invest resources differently. And that also means that we politicians need to put our weight behind the redesign of services rather than seeking to defend the status quo at every opportunity for fear of the censure of the public. That is where our leadership will be pivotal. I recognise, of course, as we all do, that big complex institutions like hospitals need stability, and I don't think that the changes afoot place that at risk. Indeed, I would confidently predict that the new cadre of chief officers are not going to be arriving with their JCBs on the grounds of our general hospitals within the next 48 hours. I'm sure the line managers might have something to say about that if they did. But the serious point here is that strategic commissioning requires a sober, long-term and thoughtful approach to redesigning services to meet the changing population needs. In short, it requires a permanent revolution. One final observation before I finish. The resource challenge our public services face are profound and becoming more challenging each day. Strategic commissioning and better service design will ameliorate some of this challenge. I don't believe it will eliminate it. There will be a point then when all politicians in Scotland will need to face the fact that greater levels of investment will be needed into the future to maintain our health and social care system in the face of demographic change. We had the King's Fund just last week making similar observations about the system south of the border. So, in view of the wide range of leaders in this room today, I would urge you to get round the table, address these longer-term strategic challenges and deliver a revolution. Thank you for listening.